Good morning. So today, what are we talking about? Hello? Hello? Can you hear me? Ceci here. Is anyone there? Hi, my name is Ceci. I'm based in Berlin, and I want to welcome you to Ceci, the podcast where you see what others see. In this, our first season, we're talking about colors. Good afternoon, Petra.
Hello, Ceci.
We have a great episode ahead of us.
Yes, definitely. I'm very excited to start our interview today. Our guest today is Professor Alawi Lütz. He studied and graduated from medical school at the Charité University in Berlin, where he also obtained his PhD and professorship in anesthesiology with a subspecialty training in intensive care medicine. Professor Lütz provides consulting and critical care at Charité Center for Anesthesiology and Intensive Care Medicine, also known as the Ceci 7, which covers all three campuses of the Charité University Hospital in Berlin, one of the best-ranked hospitals in the world and one of the largest anesthesiologic and intensive care centers in Europe, with over 65,000 anesthesiologic procedures performed per year and over 120 intensive care beds. As professor at the Institute of Healthcare Management of the Technical University Berlin, his research is mainly focused on improving the care and outcome of critically ill patients with ICU-acquired brain disease. The abbreviation ICU, which we will use a lot today, is short for Intensive Care Unit. Recently, he worked on new technologies related to the natural cycles of physical, mental, and behavioral changes that the body of ICU patients go through in a 24-hour cycle, known as the circadian rhythm, mainly by deploying patient-individualized light therapy. In this context, he has been awarded prizes like the Health Promoting Hospitals Award for his outstanding scientific publication, Patient-Centered Lighting Environments to Improve Healthcare in the Intensive Care Unit, and he won the first place in the competition Design and Health Management granted by the Berlin State Initiative Project Future for the all-around project called the Parametric Spatial Design concept, which will be central in our interview today. The main objective of this award-winning project, which Professor Lütz has been working on since 2013, is the development of innovative solutions that help prevent ICU delirium and post-intensive care syndrome by joining interdisciplinary forces with medical professionals, tech and healthcare experts. In his passion for investigating new interactive room concepts for a more patient-centered, holistic healing ICU environment, he has contributed with important publications like his co-authored article, Modification of the ICU Environment is Associated with Reduced Incidence of Delirium, published in Intensive Care Medicine Experimental in 2018. Having partnered with the Technical University Berlin, one of the four institutions of the Berlin University Alliance, Professor Lütz has succeeded in bringing innovative and evidence-based solutions to the patient's bedside. And we are lucky to have him talk to us today about intensive care unit medicine and the healing power of light and color.
Welcome, Professor Lütz. We are thrilled to have you here at the studio with us.
Thank you very much. I'm happy to be on the show.
So let's start our questions. As a researcher of intense care therapy and narcosis methods, you have been in close relation to two subjects, these being postoperative delirium and post-intensive care syndrome, suffered by patients which have undergone surgical procedures and anesthesia. Could you define in simple terms the difference between the two of them and explain when do these complications manifest after a surgical procedure?
So delirium is a major healthcare problem we have, especially in the intensive care unit. It refers to an acute brain disease, which occurs normally within hours or days. And the core symptom of delirium is inattention. So patients are not able to follow simple tasks or to communicate. And what we often see as well is that those patients have a unnormal behavior, which means they are either hypoactive or hyperactive. Hyperactive means they don't open their eyes when you want to speak with them. They don't follow very simple tasks, or they're very hyperactive and aggressive. In the intensive care unit, we mostly see patients with delirium, which are hypoactive. So when you look at those patients, you probably think everything is normal with this patient. He's very calm, he's sleeping, but it's actually what is often ongoing is a new brain disease, what they have as part of their critical illness. Post-intensive care syndrome is something or summarizes a syndrome which occurs after critical illness and often persists after discharge from the hospital and persists even throughout days and sometimes years. And it subsumizes a syndrome which means you have problems in 3 domains. The one domain is cognition. So those patients have cognitive disabilities. So there's a bunch of literature and studies showing that approximately 1/3 of patients which were healthy in terms of cognition before they were admitted to the intensive care unit, after discharge, they have a new brain disease, new disease of the brain, which means sometimes is in the room of Alzheimer's disease. So it's a very severe cognitive disability which can persist. So this is the first very important domain of post-intensive care syndrome. The second one is physical disabilities, which occurs in the room of critical illness myopathy. So they have problems with their muscles and with their strength. And the third domain is psychological disabilities, which means something like depression or PTSD, referring to post-traumatic stress syndrome. So delirium as the acute problem in the intensive care unit, and post-intensive care syndrome, the chronification of a process which begins in the critical or in the intensive care unit as part of the critical illness.
That sounds like quite complicated consequences. Could you tell us what can be done to prevent these consequences at the intensive care before releasing a patient, or maybe to supervise them afterwards?
Yes. So there are a bunch of risk factors that lead to delirium. One of the major risk factors is sedation. So to clarify that, sedation means that normally patients, when they come to an intensive care unit, they are seriously ill, right? So, and what we do with those patients normally, and which was done for decades, is to sedate the patient. So to give the patients sedatives that makes them paralyzing, and so non-physician often say sleeping, but it's not a sleep, it's just a deep sedation. So patients are unresponsiveness. And professionals thought for years that keeping patient at this status during their critical illness is something good. So we want to protect the patients to experience their severe illness. And it started, I think, probably 10 to 15 years ago that actually when we are trying to protect the patient by sedating them, that this is something bad for the patient. So there were more and more studies showing that sedation increases mortality, that sedation increases the risk for prolonged mechanical ventilation, prolonged intensive care unit stay, prolonged hospital stay, and also the risk for developing delirium. So there's a over threefold increased risk of developing acute brain disease when you sedate the patient. And that is not referring to a long-term sedation. So sedating patient for weeks, for example. It means within the first 48 hours. So when the patient comes to intensive care unit and you do a deep sedation during the first 48 hours, you have this massive increase of risk for a poor outcome. And that is something, was something pretty new 10, 15 years ago. And it induced some sort of, revolution in the intensive care setting because
It changes the whole mentality, right?
absolutely. So this was the point where we had to think about having awake intensive care patients. So that was absolutely unusual. So when I started my residency in intensive care, all the patients, or most of the patients which were seriously ill, were paralyzed and were deeply sedated. And that is starting to change, at least in big and university hospitals, because of course it takes time to disseminate through all the hospitals, because it's a real change in culture how you treat those very, very sick patients.
That is so interesting, and so it's like a threshold, like a new era of medicine.
Absolutely.
I'm talking about this new era. We have here before us some images of the rooms of Charité's intensive care unit, which are part of the Parametric Spatial Design concept, which was developed by Graft Architects, the design agency Art Plus Com, and the Berlin Charité Clinic Ceci 7, where you work.
Yes.
Within the framework of joint venture funded by the German Federal Ministry of Economics and Technology.
Exactly.
So these rooms look as if they were taken out of a science fiction movie. Could you please explain the audience what is this concept about and what are the components of all of this all-around project?
Yes. So just to clarify that clinically, so I told the audience that we have a change in culture how to treat those patients. So we are moving from paralyzed patients to awake patients. And if you try to do that in the clinical routine, that is not so easy, because when patients wake up, they can't move. They don't know where they are. They are anxious. And it's a sort of helplessness they feel. And in that case, of course, the environment matters, because before it doesn't need to look nice and calming the patient. It just needs to be functional. But now when you have awake patients, of course, the environment is a very important aspect of the treatment concept. Because the problem we have when the patient's awake, they are very anxious, they are agitated. And what happens if you can't solve the problem rapidly? What the clinician normally does is to give sedatives again and paralyzing the patient. But that's not what we want. So that's why we were a little bit in a situation where we couldn't achieve the awake and calm intensive care patient. And we, of course, talked a little bit to the patient, observed them, did studies, and there was a need to somehow create an environment that supports the patient to be awake in this critical situation, but at the same time calm, not being anxious. So that's why we thought about, okay, what has an environment look like? What must an environment look like? And that's how the project started, actually. And there are different components, of course, in this concept. So the first important component was to create an environment from the patient's point of view, in which a patient is not exposed to all this technical equipment which a patient has. So we created corridors behind the patient where you can move all the different machineries away from the patient's point of view. And having a nice furniture, wooden colors, and also furniture which the patient can have photos from the relatives. So having a sort of nice, calm, and protected environment. The second thing is we wanted to achieve. A second component is, of course, noise reduction. So all the material is specifically chosen to reduce the noise levels in the rooms, especially during night, because it's a huge problem. The patient don't sleep very well, and then of course they have a disrupted day-night rhythm, and that also is a risk factor to delirium and also makes stress. So we know that the noise levels on the ICU are very, very high. It's like trying to sleep on a highway. It's not possible to do that. And recommendations from the WHO, they recommend like 40 decibel, and on the ICU it's like 80 and above. So it's very loud. So we tried that. Also considering the traffic in the rooms, so recreating the traffic in the rooms so that you have less noise in the rooms, like having an observation room, reducing the traffic in the room. So this was a second important thing. And the third one is lighting conditions. So light is a very, very important aspect of circadian rhythmicity and also of the sleep-wake cycle. We know that almost all patients on the intensive care unit have a disturbed day-night rhythm and circadian rhythm. And we also know that the lighting conditions are inadequate on the ICU. So it's too much light during night, and it's not enough light during the day to induce a normal circadian rhythm. And that's why we developed a new technology with this very huge light seeding we have developed during the project, which of course has not only circadian lighting, but also different features which we may be going to talk about.
Mm-hmm. So now we know that light and color are a central part of this concept. And one of these functions, as you were mentioning, was the regulation of day and night light. Does this regulation of light also has a correlation with the healthy sleep patterns through day and night rhythm resemblance? And if yes or no, you would tell us, what would this correlation be?
Sleep in the intensive care unit is a very difficult topic because what you normally do to evaluate sleep in humans is to do an EEG. This is very well studied in healthy subjects and in non-intensive care unit patients. In intensive care unit patients, it becomes much more complicated because those patients receive a lot of medications. They're probably sedated. They are on mechanical ventilation. And all these things during therapy are creating artifacts in the EEG. So it's very hard actually to evaluate sleep scientifically in intensive care unit patients because all these criteria which were developed were not developed for the intensive care unit patients. Anyway, we know that so when we observe patients and when we do interviews with patients, that they have a dysregulation of their sleep-wake cycle. And we also know that they have a disturbed circadian rhythm. And that you can, for example, measure by melatonin. So melatonin is a sleep hormone, and it's normally increasing when in the evening and during night. And that is something which doesn't work very well in intensive care unit patients. We know that. So we have a lot of indications that this is not working normally in intensive care unit patients. And we have especially a problem for intensive care unit patients with very high melatonin levels. So you don't have like the typical rhythm during day and night. You have in the sickest patients mostly melatonin levels which are very, very high. So during all the 24-hour period. And that's why light maybe is a promising therapy in this context. Because normally in healthy adults, when light is falling on the retina, on the eye, it decreases melatonin. So it's the most important stimulus for the day-night rhythm. And that's why we are using this lighting technology as part of the room concept to sort of resynchronize the patients to a normal day-night pattern. If that has also a direct effect on the sleep EEG, we don't know.
You don't know. That's why they say no cell phones and no tablets before going to sleep, right?
Yes,
What you were
absolutely.
mentioning.
Yes.
And besides this important role of synchronization of the sleep patterns, what other role you would say that color and light play in this all-around concept?
So I think the second important effect which light can have specifically in those patients is reorientation in time. So most of the patients in the intensive care unit, they have a total loss of when it's morning and when it's evening or when it's night. So if you have lighting conditions in the room, so the light becomes very bright during the day and it becomes more darker in the evening, they sort of get an intuitive feeling about the time of the day. And this reorientation is very, very important for the patients. It sounds very basic, but if you have been in an intensive care unit and when you look at these very sick patients, you understand why these simple things really matter. And then, of course, the guidelines are telling us, okay, you should equip rooms with a clock so that patients can look at. But this is often problematic because patients can't read the clock very well. It also depends where the clock is. And it's also, so when you have an analog clock which says 1, they often don't know, is it 1 p.m. or 1 a.m.? So it's not so easy. And light and color gives you the option, especially if it's such a large surface area which we have in these new rooms, that patients are able to intuitively feel the time of the day. So somehow bringing the sky from the outside into the patient's room.
Professor, when you're talking about that, I can absolutely relate this into another subject, which is absolutely contrary to the health area. And that would be like people kept in jails, how they sometimes use light to break the person, to take him out of this conscious adaptation to the daylight and nightlight rhythm. So it makes totally sense to do it the other way around, to heal.
Yes, absolutely. And but what we did then actually with this new technology we developed is that we not only have this bright white light therapy implemented, but we are also able to show colored moving objects. So this is the second part of this technology. For this purpose, we developed different content layers, let's say. And content layers means different layers which show different coloring objects, which have all a specific purpose. So the very basic layer in this technology is the sky. So we're showing the sky, and the patient will also see sunrise and sunset and changing of the color of the sky. So this additionally helps the patient to feel the time of the day, and also to make the bright light feeling more nice than just looking into a bright light. And the important thing is that, for example, this basic layer is parameterized in real time, which means it's not like a movie you see every day the same way. It's actually parameterized by real-time weather data. So when it's more cloudy outside, it's also more cloudy in the rooms. If it's very sunny, it's also very sunny in rooms. And also when it's summer, the sun gets up earlier. So we wanted to somehow that the patient gets connected still to the real outside world, because the world in the intensive care unit is so artificial and so different, and it's not really healing and nice. So this kind of technology and this parameterization should help the patient to be in contact with the outside. And of course, light can also be harmful, of course. So especially when you're dealing with these very sick patients. So, of course, if you're showing moving objects like moving clouds, for example, in this very first layer, then and patients have already delirium and they have sort of hallucination, which can happen. Then if they look at this large surface area on the screen and they see moving objects, that maybe can trigger delirium. So you don't want that. And that's why it's so important to not use pre-recorded videos, but to actually incorporate real-time clinical data as well to adjust the visuals in real time. So for example, delirium monitoring with scores that are validated are used on most of the intensive care unit. So for example, if the nurse does a delirium monitoring and the delirium monitoring reveals that the patient has delirium or an increased delirium severity, then all the visuals the patient will see will be static. So there's no moving objects. And that can be changed every hour. But it's not something the nurse has to do, having extra work to adjusting the visuals on the screen. They just have to do what they do every day and every hour, and the visuals will parameterize or adjust in real time.
This is fantastic.
Yeah. So could you say, with having the patients being awake in this new concept and with the new innovative spatial design, the new rooms, it really helps preventing that the delirium or the post-operative syndrome occurs? Or can it still, what you just mentioned, it still can happen, but in less cases? Or can you really prevent it?
So that's of course what we want. What the goal is to improve patients' outcome. So after finishing the first pilot room for this concept, we started a first observational study where we compared the outcome between patients treated in the standard rooms compared to patients in these new rooms. And we now have the first data available. I can't talk about the unpublished results, but I can talk a little bit about the published results, also in the abstract, which showed that patients in the modified rooms have a significant reduced incidence of delirium. So there's less delirious patients in the modified rooms compared to the standard room. And this is a reduction from 70 to 40% of patients. So it really makes a difference. And we can also see that in delirium severity and delirium duration. This is not published in the abstract, but we have the data now, and we see that the severity and especially the duration of delirium is reduced by more than 50%. And especially duration of delirium is important. It's even more important than the incidence of delirium, because studies show that the longer the patient is in delirium, the higher the risk for developing post-intensive care syndrome and cognitive disabilities. So if you have a lot of patients who probably have just delirium for 8 hours or 1 day, it's not nice for the patient, but it's outcome-wise, it's not such a big deal. But when patients have persistent delirium, that makes the real difference in terms of outcome. And we could show that this is reduced by more than 50%. So this is a very good result.
That's amazing. So the ceiling that is used, it's called the Healwell lighting system, and it conveys a simulation of the natural rhythm of daylight. And these have also been installed at the German Heart Center in Berlin and other hospitals in Germany, the UK, Netherlands, Central Europe, Middle East, and South Asia. And we spoke about it already, but a pilot study to investigate the general effects of this system revealed that it does improve patient sleep quality and the mood of patients, as well as of the health workers. That's also quite important. And thus increasing satisfaction in both groups. And do you have any additional scientific proof results of patients being treated in these intensive care rooms?
Very good question. So just to clarify, the Healwell system, which was investigated in those studies, is a complete different technology, what we have built. So the Healwell system is something we also had installed in 2 of our rooms before the project started. And we also, at this point, it was like 15 years ago, we already initiated a study, and we had the first patients included, and we saw it didn't work. The most significant problem was that you have a very small surface area. So you have, with this small surface area, you have to apply very high light intensity, which then induces glaring effects to the patients. So patients will not tolerate it because it starts glaring. That's also the reason why we developed a lighting system which has this huge surface area. So now you are able to apply very high illuminance levels without glaring the patient.
We can see in the pictures that they cover the whole side of the patient, right?
Yes, exactly.
And of course, there's a huge difference between somebody that's going in and out for the hospital for a very light surgical intervention, as if someone is there, as you say, in these conditions in the UC.
Absolutely, it's a complete different technology. Surface area is more than 20-fold that big compared to the Healwell system. So it's a completely new technology. Otherwise, I mean, if we already had a technology which works, there were no need to develop something new. So I think that is one of the major problems that at this point where the previous studies started and we had the Healwell system, there was already the idea that we need lighting and color in critical care to support the healing process of patients. But the device was wrong and the dosage was wrong. So we didn't know how much light do we need to give the patient and what is the right equipment to apply it so that patients can tolerate it. That's another issue. But and the second point I want to make when you're referring to this study, which was very well done, but these interventions only work if you have this culture change in treating ICU patients. So, and that was also a problem in this study because a a relevant amount of patients were still sedated. And of course, if you can have the nicest lighting equipment on your ICU, if your patient's deeply sedated, it will not work. So it has to go hand in hand. The cultural change of basic clinical treatment and new technology.
And exactly. And what you were saying, this ability to be able to construct something individual for the certain patient cannot be produced in a volume product.
Absolutely. Yeah.
So I would say then another important characteristic of this innovating concept is its inclusiveness, since it makes possible to tailor it according to the patient's individual needs. The hospital staff can enter, as you said, the desired parameters, and the luminous areas creates images and moods of light adapted to the situation of each patient, thanks to software created by Art Plus Commons.
Yes.
So could you give us some simple examples of how do these tailoring work?
Yes, sure. So I think I already mentioned it regarding the basic layer sky. So we talked about different content layers. So the sky is a basic layer. We can talk about another layer which is very important, and that is the layer of nature and green color. So we know from some studies which were already published in the 80s that surgical patients after anesthesia and surgery who look in a green garden compared to patients who look on a brick wall, that they have less pain and also need less opioids. So there is, in the non-intensive care setting, already some evidence that when patients think about nature and green color and have this association in their mind, that this somehow works to feel less pain, because pain is a subjective, something subjective. It's always very difficult to measure it objectively. And that kind of works in non-ICU patients, and that's why we thought about somehow using this evidence and to implement it in this technology. So what we are doing now on the intensive care unit, of course, we can't realize that every patient looks into a nice garden. That will not work for most of the ICUs. So we bring the green color in the association with nature on this large lighting surface, and it works like that every patient will see for at least 5 minutes green leaves on the screen, which overlays the white light. And pain is also something we measure routinely on every ICU. There are validated scores. Mostly if you have a responsive patient, you ask a patient, how much is your pain? So 0 is no pain and 10 is the worstest you can imagine. And this number is then entered into the system. And we are using these parameters to parameterize this, let's call it green layer or green content layer, which means that the higher the pain, so the higher the pain score, the more minutes per hour the patient will see this content layer, and the more surface or the more green leaves the patient will see on the screen. So this is a very simple description how real-time parameterization works in the software. So in terms of the green layer or pain layer, it means the more pain you have, the longer the duration of this content layer will be seen, and also the more green leaves you will see per hour.
Professor, another area of research we would like to know about is addiction and its influence regarding sedation and recovery in intensive care. In your experience, how relevant is substance addiction in the recovery of patients in the intensive care?
Yeah, I think it's an important topic. Patients who have addiction, alcohol use disorder, drug use disorder, they have an increased risk of having problems after surgery in the wake-up process, and also regarding delirium. It's a little bit different. So the as a ICU delirium we see normally is not the same as delirious state you probably see in a patient who has a drug or alcohol use disorder. It also can somehow overlay. But it's really important to know if a patient has alcohol use or drug use disorder, because in those cases you have a higher risk, and you also, in those patients with an alcohol use disorder, for example, you definitely have to treat in most cases also pharmacologically. Maybe the most important difference, because in non-drug drug-used delirium, there's no proof for any pharmacological treatment, which is not the case in, for example, in alcohol drug use disorder related delirium.
And related to these and regarding the ability to tailor the software to fit individual needs, we learned from the autistic perspective in a previous chapter of Perspective R&R that it is possible in children in the spectrum, perhaps also in adults, that I don't know, to develop an addiction to the brightness of a certain color light. Would this kind of addiction be identified while using these illuminating ceilings? And if so, could the situation be adjusted using these software to avoid triggering these kinds of addictions?
It's a complicated question. The problem is that we have very little data regarding the dosage and the spectrum which is best for critically ill patients. So all the data or the lightning schedule we are using, and also spectrum we are using, it's all derived from studies coming from healthy adults or seniors. But I'm pretty sure that the needs for critically ill patients will be different. So this is something to find out, and that is the same regarding your question. When you're looking at children, there are different demands and different patients. So it's too early to make really honest comment on this, because the data are missing. But I think what we can definitely say is that when you use lighting technologies, circadian lighting and also colored lighting, that it needs to be adjustable, very simple and very fast, because otherwise you will induce problems.
Professor Lütz, I would like to go shortly back to the subject of colors. You just mentioned the healing power of the color green. And what would be a reason to use other colors like red or blue? Do they have other powers for the patients? Or could you explain a little bit about the different color uses?
What I'm dealing with is with a perception of intensive care unit patients. And especially in intensive care unit patients, there's not much evidence about it. So I talked about the different content layers. We have several others, but we also have an active content layer. So we just talked about that the patient just looks at colors and moving objects and bright light. But we also incorporated interactive lighting, which means that we are using moving objects for cognitive training. Because sometimes if you're in an ICU and you're getting better, it's also very, very boring. And I also talked about attention deficits as a core syndrome of the acute brain dysfunction. And what we are trying to do with the lightning is to train patients in a very simple and playful way. So, for example, we have short interactive games on the ceiling. So it's also correlated to nature image-wise. So the patients see fireflies which are flipping around the screen, and we are giving the patient an iPad, and the patient has to move the fireflies, for example, from the right corner to the left corner. So that sounds very simple, but for an intensive care unit patient, it's very hard to do it. So the patient has to look, focus attention, and also focus attention on the screen, and also focus attention on his fingers and on the iPad. So it's a sort of very playful, joyful, hopefully joyful, cognitive attention training. This is also how we are using lightning on this screen. So there are some studies where from the US where they tried to improve cognition in intensive care unit patient by paper and pencil work, but the results were very frustrating. And that was also related to that patients didn't want to do it. It was very boring. Patients felt like in a sort of testing atmosphere and didn't want to do it. And using lightning technologies in this very interactive, playful way is something which can be nice for the patient and which can also be done with family members when they come to visit. So it's a sort of playful, easy gaming which can motivate the patient and can be somehow an interaction between staff and between family members. So this is something we are using as well.
And regarding color and the association we experience through it, you receive patients from all over the world, and you have experienced obviously diverse perceptions of specific colors during recovery. Would that happen also based in cultural differences?
Yeah, I'm pretty sure that this is relevant. So far, we don't have studies done on that, but that will be definitely the case. So looking into the future, I would say the circadian lightning as well as the colored imaging needs to be tailored not only to the clinical condition of the patient, but also to demographic data. So depending on age, depending where the patient comes from, what religion the patient has, and so on. So there will be different associations and different perceptions which needs to be addressed. So the more data we have now, the more appropriate we can adjust the algorithms behind that technology. So you talked about the HEWA system, which was installed in some of the other hospitals. But this is also the case now with this technology. So this technology is now a certified medical product, and it's already sold in hospitals in Germany and Austria and also in Switzerland. And that enables us to do multi-center studies and to collect a lot of data from a lot of patients. So right now we have only a very small study at Charité. So it definitely has to get bigger to collect all this data, and then someday we will be possible to adjust all the visuals and also circadian lightning better to the individualized or the individual patient.
Well, this project is, of course, proof of an out-of-the-box thinking. And what personal or professional experience and research, you were talking in the beginning also about it, awoke your interest in easing patients' healing process, which was the delirium, right?
Yes.
But I would like to know if there's another experience as a professional that you said there should be parallel or alternative methods to medication.
As I said before, when I started my residency, I was also a little bit shocked about seeing all those patients being paralyzed for days or even weeks, and not considering the patient's perspective. And I mean, of course, everybody wants to help the patient, and when patient comes with a severe pneumonia or something like that, we treat him the best we can. But I think in a situation where you are that critically ill, there was definitely a lack of getting in the perspective of the patient, and that became even more relevant at the point where we had to wake up the patient and not paralyze the patient. And it is a sort of concept from hospital to hospitality, so that the perception of the patient really matters, and that we have to rethink how to adapt the environment in critical care. You talked about it looks like a futuristic ICU. Some might say, oh, this is like a luxury ICU for patients who have a lot of money or something like that. But I don't think that way. I really think that, because luxury means that you have something which is more than necessary. But I think this concept is not that. It takes the perspective of the patient and tries to take the emotions and the feelings of the patient seriously, and sort of also empower the patient to help
Recover.
to recover faster. Exactly. So it's not just about a therapy and machines and
But making him participant of the process.
make him participating in the process, and the room somehow should motivate the patient to get involved in this recovery process. I think that is one of the key elements.
You just mentioned the word money. The development of these innovative intensive care rooms were funded by the Federal Ministry of Economy and Technology. And as we look at the pictures of the rooms, they're really amazing. But also, they seem quite expensive compared to the regular ones. And what could you say about the economic feasibility or the benefits to build only ICU rooms like this in the future?
Okay, first, it's true that, for example, having such a lighting technology implemented in the rooms will cost the hospital a little bit more of money. But I don't. So the problem is always if you have to refurbish or rebuild a room. This is always very expensive in a hospital. But if you build it from scratch, I think it will not make that much difference from the financial point of view. Rebuilding an ICU is always expensive, even if you do it the wrong way, let's say. But the topic, I think that is something we want to investigate also with the Department of Healthcare Management, which I'm part of now, together with Professor Busse, where we are trying to evaluate, okay, if we invest some money in this new environment, and if we are able to show that it supports the healing process, so that patients have less complications, that patients have can be discharged faster from the ICU, that this will also gain money for the hospital. So
And on the long run, as you said, with the cognitive problems that would come along if
Yes.
it's not well treated and so on, right?
And it's also it's also an important point for the insurance companies as well. So healthcare problems related to delirium is also a very important social economic problem. So the cost related to delirium has somehow in between diseases like cardiovascular and diabetes. So it's really also money-wise a healthcare problem. And so by implementing interventions like this non-pharmacological room concept very early can spare you money in the long term. But that needs to be proven, of course.
Professor, the LEDs from these colorful ceilings exude warm and cool colors that, as we have been learning, provide a biological effect to promote healthy sleep patterns in some cases, and so on. Now, this warmth and coolness is visual. But what happens to people who are visually impaired and who rely on other senses to interpret their surroundings? And as an example, there's a pair of studies from the University of Washington that show that the brains of blind individuals are better able to represent sound. Besides the proof sound element that aims to wind up noise in the room's part of the parametric spatial design concept, have you thought about introducing music or any other component to stimulate other senses to assist patients' recovery?
Yes, important topic. We thought about that, but that was somehow then where the resources were missing to invest in other domains. I think auditive stimuli are also a very important, must be an important part of the concept. It's not that far developed in our root concept as it is for the lightning, but it's definitely on the to-do list. I think that the first step we implemented here is that we reduced noise, especially in the night. So we also published a study about that, and we saw that the noise levels were dramatically reduced, especially in the night, compared to noise levels in the standard rooms. So that hopefully will support the physiological sleep in patients. But of course, I think what is important throughout the day that you have sessions where you introduce specific auditive stimuli, but but also session where you have absolute quietness. So there are very very interesting studies about that. Also talking a little bit about the sound of silence. So which means cognitive stimulation not only happens when you have specific auditive stimuli, but also if you have absolute silence, which are different neurologic networks which will be stimulated. And that's very, very interesting. I think, we definitely have to develop solutions for that as well. What is problematic? What I can say in terms of dealing with noise and auditive stimuli is earplugs or something like that. Because when you do research in this field, you will see a lot, or let's say some studies investigating earplugs, but also eye mask to somehow support the day-night rhythm and sleep patterns, and also to reduce delirium. Because that sounds very easy and it's not expensive. But the problem if you do that in the intensive care unit is that patients, they have no sensory input, and you probably say, okay, if the patient is healthy, they just can take the earplugs out or the eye mask off. But in the intensive care unit, patients often can't do that by themselves because they are so sick and so weak. So you always need an assistance. And we experience with this technology or with eye mask and earplugs on intensive care unit as well in the very sick patients. But these patients then often developed anxiety because they didn't know what is happening. Is the nurse still on my bedside? And they couldn't take the earplugs or the eye mask away. And this is sort of problematic to use, especially in the very sick patients.
And besides the senses of seeing and hearing, are there any studies on stimulating other senses, like maybe touch or smell, or are there plans to study that?
Yes, definitely. We didn't incorporate this in the current concept. I would definitely say something like smell is very important, because on the ICU, of course, it doesn't smell very nice sometimes. So I would definitely say, yeah, also working. So everything which is sort of sensory input, I think can be important and supportive for those patients. I think there's a lot of a lot of research topics to be investigated. In the intensive care setting, we are at the very, very beginning. So as I said before, it started like 10 years ago that we are awakening patients on the ICU, and that patients starting to perceiving where they are treated. So we are very early, but we are trying to do our best to get new insights also on that. Yeah.
Professor, we have not talked about the most important element of this concept, and I would like to close our interview with this question. We asked one of our previous guests, Magnum photographer Gregory Halpern, to imagine himself as a patient in one of these intensive care rooms and think what could be the reason that colors help in the recovery of patients. He closed his eyes and pictured himself before one of these changing, colorful ceilings. And after thinking for a moment, he answered,
"Colors seem somehow pure. Maybe even there's a holiness to color that maybe can create hope, or a reason to go forward."
Now, if you allow me, I want to ask you to do something that I'm sure you have done many times in real life. I want you to please picture yourself or imagine yourself holding the hand of one of your patients or holding your patient in some way. This person has his eyes closed, and you can see all of these beautiful colors dancing over both of your heads. In your experience, would it be fair to say that just like Gregory thought about colors, that there is also some sort of holiness to the human element? And what role then would the human element play in the recovery of a patient?
Of course, the human factor on the ICU, that's really, really important. And it's especially also in Germany important, because in some countries you have a much better nurses patient ratio, and in Germany it's usually like one nurse to two patients or one nurse to three patients. So for a nurse, ICU nurse is really hard work, very, very busy work. And I think all the nurses there are very, very motivated to do the best for the patient, but sometimes it's just too much work and it's too hard. And I think an environment, I mean, the environment we created in these rooms are not only for the patients, but also for the staff. So it also has an influence on the staff. So if the staff feels better, which we think they do when they're working in this kind of rooms, they've also, that maybe enables also the staff to be better connected to the patients.
And you coming like with a patient and saying you're doing well. I think when a doctor comes and says you're doing well, that really has a lot of weight.
Yes, absolutely, and also the feeling that this message is like honest. So if the nurse or the physician comes into the room and also has a is in a good mood or in better mood, maybe that also related to the environment, then then that makes a difference also for the patient.
Thank you, Professor Lütz, for your time and a very clear and fantastic interview.
Thank you very much. It was a pleasure.
Thank you, Professor Lütz. Thank you, Ceci. And if anyone listening would like to learn more about the parametric spatial design concept or is interested in supporting this amazing project, you will find information links in this chapter's description.
Thank you, Petra, and thanks to our listeners wherever you are for having allowed us to share time with you. We will see you next time. Bye-bye.